Hi, this is Dr. Cliff Gronseth coming to you with another Dr. Cliff's Riffs. Today we're going to be talking about knee pain. As you know, many people will have knee pain sometime in your life. It's probably the second most common complaint that we see patients for, other than back pain. And the statistics are that if you're over 45, you've got about a 25 to 50% chance of having knee pain sometime in your life. So if you haven't had it yet, stay tuned and hang on. So today we're going to be talking a little bit about the overview of knee pain. How do you approach it from the spine west side, and what to think about? What are the big red flags to be concerned about, other than the wear and tear of life? So there's two main types of pain. There's the acute pain, which is the sudden, you fall on your knee, you twist your leg, somehow you got an acute sudden trauma. That is a whole different set of possible etiologies compared to a chronic, degenerative, this is life kind of knee pain. So there's really two separate thought processes that go into evaluating a knee injury, a knee pain. Let me go over the anatomy really fast. Not that we expect you to become expert physicians and clinicians with a quick overview, but I want you to understand the complexity of the knee. The knee is actually a hinge joint, and that joint is based on the femur and the tibia. There's another bone called the fibula, which really just is a sidecar on a motorcycle. It really doesn't do much other than attach muscles. The main joint space is right here. That's where the load bearing occurs, along with the kneecap, also known as the patella, which has cartilage on top of the bone so that the bones don't rub on each other, and it lets them glide like Teflon. If you have an acute injury, you can break a bone, of course, and you can tear a lot of other things. But over time, you can wear out the cartilage on your knee, and that will cause the osteoarthritis that you hear of. If you go out a layer, you can see that the knee is held together with these straps, ligaments, that really are stabilizers for the knee. They don't usually tear unless you've got an acute injury. And a chronic injury doesn't affect these, other than if you've got a worn out knee where it really starts to chronically stretch the ligament, then they can have stretching and some instability and some micro tearing that goes on. But generally, these ligaments are for athletes or for falls when you've got an acute injury that occurs. You also have blood vessels that go all around the knee, and they can indirectly cause knee pain. And then you've got muscles that attach to the bones, allow you to move your leg, bend it, twist, etc. And it also has the muscles with the tendons that attach the muscles to the bone. And those can degrade over time. They can also tear suddenly with an acute fall like we talked about. But by and by, the muscles and the tendons stay fairly stable, and then you've got the overlying structures, which are the larger muscles that connect up to the hip, and you've got the nerves that wrap around the knee in a, let me see if I can find it right here. You can see this little yellow spaghetti looking band here. That is a nerve, kind of like the funny bone nerve or the ulnar nerve in your elbow, which can be very exposed because it sits right on top of a bone that makes it vulnerable to injury. So if you're a leg crosser, or if you happen to hit your knee, the side of your knee on the bone, it's possible to get a little bit of a nerve injury. And sometimes there are some fluid collections that can affect that nerve and cause numbness, weakness, tingling, etc., and even cause a complete nerve dysfunction. So that is the basic review of the knee really fast. The posterior knee tends to be a nice big vacant hole where fluid can collect. We'll talk about that in a little bit. And then you've got the blood vessels in the backside that can cause problems for those with atherosclerosis or vascular disease. So quick tour. So let's review some of the imaging that we might see. So here you can see a fairly worn out knee. You can see that the inside of these two knees are thinned out. You don't see this little black spacing between the femur and the tibia here. So the outside of these knees look like they have cartilage. The inside is bone on bone. And if you look at the angle of the knees, they kind of bow out, kind of like a cowboy, as opposed to this kind of x-ray where you've got kind of a knock-kneed type of configuration, and you can see that on this knee, you can see that the spacing between the bones is still relatively well preserved, but the other side, the outer side of the knee, has worn out over time. And that can happen if you are a kind of a knock-kneed person, or if you have feet that pronate. Get myself back in focus. If your feet pronate and they go in and causing a knock-kneed type of pattern in your knee angles, simply raising your arches in your feet and putting anti-pronation devices or sneakers that keep your foot from falling down can possibly prevent this from wearing out as quickly. Sometimes it's just a matter of time, and you only have so many rotations on the tire before the tread starts to wear out. Now, a pristine knee will look like this. You can see this is the floating kneecap here, and you can see there's nice spacing between the patella and the femur here, as opposed to this poor knee that shows complete loss of that cartilage, no spacing there. This is literally bone on bone. You can see the bone is roughened out, and then the other side of the kneecap or the patella still has good cartilage, but this is going to cause quite a bit of pain, especially when you go up and down stairs. So there are other things that can cause knee pain besides just wear and tear of the cartilage. You can get torn meniscus. Here you can see a little bit of a white shadow in the joint space, and you can see there's a little bit of white fluid here. That white line inside of the joint space is actually probably some gout, and that sits inside of the joint, and you can see these gouty crystals there, and you can even see this little calcified bit of meniscus, which is like a rubber ring around the knee that gives it some stability. So how do you diagnose some of these things? Well, you've got the x-rays like we just saw. We also use ultrasound quite a bit. Ultrasound is a great tool to evaluate some of the knee structures because you can see inside real time without any harm. There's no radiation like you have with the x-ray, and it can show even smaller features that an MRI may not be able to show. Sometimes the MRI has the advantage of looking deep inside the joint, but the ultrasound can have resolution that sees even micro changes. Here's an example of cartilage seen with ultrasound on the end of the femur, and you can see it's got a nice tread. This black layer is the cartilage that sits on top of the bone, which is this white layer, this little white valley below. This is all the soft tissue tendons and other structures, but the key thing for osteoarthritis is this nice thick layer. Now, if you look at this one, you can see that here you've got nice thick cartilage, but over here it's starting to thin out. It's not as, the treads are much smaller than over on this side, or you can start to get some irregularity. You see that you start to get these kind of wavy lines in the cartilage, which causes that kind of crunching sound in your kneecap or your patella when you're going up and down stairs. And if you if you advance, you can see it. The treads or the cartilage really gets thin in some places, and it might be normal other places. Here, the cartilage is thick. Over here, it's thick, but there's one spot, and that one little spot is enough to really cause problems. On an x-ray, this might look like it has normal spacing. So you think, well, the x-ray doesn't show osteoarthritis, and yet there is, because you can see it on ultrasound. Here's an example of a divot that's taken right out of the cartilage. You've got nice thick cartilage here, nice cartilage over there, and you can see this one area where you just have exposed bone, and then this one shows almost complete loss of the cartilage, and this one is going to hurt quite a bit. Now, an MRI has its benefits as well because you can see inside the bone. Here you can see that the bone shows some irritation and there's some fluid collection around the joint space. This is a picture of the ACL, the anterior cruciate ligament, one of the ligaments that stabilizes the knee. You can't see that well with ultrasound. You can see it sometimes, but not as detailed as an MRI. And then this MRI, of course, shows kind of an end-stage knee that doesn't look so great. You can also see with ultrasound gout and pseudogout, which is basically an accumulation of crystals that develops inside of the joint fluid, and they can settle into the joint space and cause quite a bit of pain, almost like having sand in your gearbox of your car, and it will just grind away and cause pain. The other possible sources of knee pain can include a blood supply issue. Here you can see there's a little bit of white calcifications, not in the knees, but actually in the soft tissue of the thigh, and you can get knee pain from poor circulation. And like we talked about, you can actually have a meniscus, which basically tears away from the stump of the bone and is extruded over time. And in this case, the deep fibers of the ligament have been torn, so you can see fluid on either side of the meniscus there. You can sometimes get what's called a Baker cyst. You get fluid collection that goes backwards into the back part of the knee, and that'll give you a fullness. The body reacts to pain and inflammation by trying to lubricate the joint. So you might get some swelling that occurs in the knee joint, which will either cause some puffiness or some fullness in the top part or around the front part of the knee, or it might go to the back part of the knee and actually compress nerves, arteries, or just cause a little bit of fullness, and it's a sign of something's not right inside the knee joint. And then you can also get fractures. In here you can see this white area of bone from a tibial fracture, which would hurt every time you put weight on it. And you can't see that type of condition with ultrasound. You may be able to see it with x-ray, but a kind of a chronic compressed fracture like this, only the MRI may be able to see. Or like this image here, where you can see the little white line in the bone, which represents just a limited fracture. This was probably an acute injury, a fall, because it's a very limited area of swelling. And you can even get some significant fracture and degeneration of the bone as seen in MRI. The other thing that the collection of fluid can do is pinch the nerve. We talked about that earlier. You can see this little fluid collection, which was actually compressing somebody's nerve, causing weakness with their ankle, and that was simply a result of the arthritis, which caused swelling within the joint, which then caused compression of the nerve, which then caused weakness and numbness in the foot. So there's a whole cascade of things that develop. You can also get pain that's referred elsewhere from the spine or from the hip, And the worst case scenario is if you have cancer. And so we always make sure that the history and the exam and all the imaging does not suggest that it could be a tumor inside the bone that is causing the pain. This typically will present as pain at night, not relieved with changing your position. So that would be a big red flag for working up for potential cancer. So that's a very quick, broad overview of some of the sources of knee pain. Of course, there's many other types of knee pain that are associated with more systemic problems like rheumatoid arthritis, which is where your body attacks certain tissues in your body. There's a polymyalgia rheumatica, which older people can get. It's also this autoimmune process, which is treated with steroids, oral steroids, and relative rest. That can cause knee pain, shoulder pain, and it's usually detected by history and by blood work. So it can get quite complicated depending on what the source of the pain is. If you have any questions, certainly give us a call. We are here for you. We hope that's a reasonable overview of knee pain. If you'd like a specific summary of a topic, let me know, and we'll see if we can accommodate you. Have a great day. We'll see you next time. Take care.